for that or checking in with your physician. Risk for aspiration. So you always want to be aware of tube placement. If you always going to have a low ceiling to make sure your tube's in the right place, especially if your patient is maybe confused and tugs on the tube a little bit. You always want to be aware of where that tube is marked. So if your patient has been messing with it, okay, yeah, my tube was at 65 centimeters or what have you, and then you look at it and suddenly it's at 30, you want to be aware that if you were to restart feedings or access this tube and put something down it, it could be in a very, very long position. As a general rule, keep head up 30 degrees, but we discussed the nuances of that. Diarrhea, so this is a pretty big one. Tube feedings can cause pretty profound diarrhea. So keep in mind, if your patient begins to experience severe diarrhea, talk to your physician about that. And also providing free water hydration. This is something that you need to keep in the back of your mind is one, am I not just giving them tube feeding? I should be giving them some form of hydration, even if it's just a little bit, which tube feeding hydration can range from 30 cc's every 2 to 4 hours to 200 cc's every 2 to 4 hours. It just depends on what the patient needs. And also remember that the tonicity of the fluid that you're giving is important. So if you have a patient who is, having issues with hyponatremia, you may give them NS instead of water. You're typically not going to want to give a very high volume of it, but it can be enough to help maintain. Tube feedings are started a little bit slow, and you're gradually increasing the volume. Now, where I work, that is a prescribed rate and duration. So they'll say, increase 15 cc's every 6 to 8 hours, depending. I've even seen it up to 12, depending on what the dietitian thinks is appropriate.
Katie, do you have a question?
Sorry.
Oh, okay, no.
What?
She was stretching. I thought she had a question.
Oh, okay. Here in this photo, you can see a picture of a enteral feeding tube, which is connected to what actually the infographic says is connected to the inline suction catheter, but that is not actually what that catheter is. But either way, that tube still leads into your body. And you think that this is crazy and it could never happen. I have seen this happen. Things like this can happen, which is why whenever you're taking over the care of a patient, any line that comes to or from that patient, you need to trace it back to its point of origin, know what's going in it, how fast it's going in, is it plugged into the right place, and assessing for any potential safety issues there. Let's go through this. Parental nutrition indications. Severe malnourishment is one if you have a patient who is either failure to thrive or very cachexic. They may require tube feedings to be initiated. Stroke is a big one that I see. Patients whose swallowing is impaired by either a stroke, a tumor, a seizure, major surgeries and/or traumas. May have this. Anything that is impairing the upper airway may require that feedings via tube be used instead of taking in food. Tube feeding contains a lot of dextrose, so these patients immediately are blood sugar checks, usually every 6 hours tends to be the rule, because they are technically considered NPO. And then here it's talking about a little bit about TPN as well. Lipids are frequently given in piggyback. So this speaking specifically to TPN, you do need a central line with an IV pump and an inline filter. You're going to start it at, typically it's very clearly outlined by pharmacy on how to run this. How do you prevent refeeding syndrome with TPN tube feeds? So refeeding syndrome tends to be more of a problem with tube feeds as opposed to TPN. And preventing it, I don't necessarily know that you can. I've only seen refeeding syndrome a handful of times, which tends to involve a lot of electrolyte alterations in the patient who's being fed now who wasn't. Clinically, what I've seen is that we tend to try to back off a little bit, but support those changes. You don't want to be too overzealous about things like electrolyte repletion in the setting of refeeding syndrome. But as far as prevention goes, you're not typically moving to prevent, it's more you're reacting if it occurs. So, like I said, you need a central line with a pump and a filter for this. The therapy for initiating is typically very clearly outlined by pharmacy. You're going to be monitoring daily weights, labs, blood glucose, eyes and nose. You want to make sure that the nutritional needs are being met for the patient and they don't continue to lose weight or lose weight at a rapid pace, at which point things may need to be adjusted. Bag hangs only 24 hours. So there are two questions here. What should the nurse do if a bag is empty before the 24 hours is up, and or what should the nurse do if bag is behind and will not be in by 24 hours? So I'll tell you this, in my experience, these bags are typically timed so that the bag you're typically going to be tossing what's left and hanging in a new bag by the next duration. You're often, like it says, you're changing every 24 hours. And pharmacy is usually very aware of this and actively manages it. I have been, one of my first hospitals I worked at, they gave us huge bags of TPN, and we would almost always be throwing away a good, half to a third of the bag every 24 hours. But they try to be more judicious these days. I got another question. Are you changing the entire line or just the bag? You're changing the entire line. You're going to change the whole line, filter, bag. So when these bags come up from pharmacy, they tend to come up with a tubing and or a filter already attached to it, so that you can get rid of it. These solutions are very dextrose heavy, so they can get gunked up very quickly. And as a note, if you have a patient who is requiring, let's say, an insulin drip and or maybe they just need labs to be monitored, when you are using that TPN, there tends to be a very specific protocol where you work that is outlined so that you can draw labs from those lines without causing the residual in the lines to give you erroneous readings. If I have another line to draw from, I prefer that. That way I don't accidentally send off a line that comes back with a glucose of like 700 and some other stuff that's out of whack. One of the hospitals I've worked at, their policy was to stop the TPN for 30 minutes, flush the line with X amount of saline, and then draw the labs. It may be unavoidable at times, and just the general rule of thumb is if you need to draw labs from that line, give it a really, really good flush and make sure that if you can disconnect it, if it's not against your facility's policy, disconnect it, flush it really well to pull those labs out. So these patients were risk for infection, hyperglycemia, hypoglycemia. This is a big one, and I'll say it again, just so you're aware and that you make a note of this. These patients, if they stop the TPN, you need to monitor their glucose. Even if they're on the TPN, you need to monitor their glucose. Looking for circulatory overload, this is the big one because they're getting a rather large bag of fluid around the clock all the time. So if your patient, again, looking at those daily weights, looking at those eyes, nose. If your patient begins to become too fluid positive, then you need to make a note. Times of 9:44. So that's the bulk of this one. I'm gonna try and jump over to this farm so we can close this out. All right, can you see the farm?
Yes.
Okay. So we're gonna cover some of the different meds with a little bit more specificity. So first we have our histamine 2 receptor antagonist. This is something that we are gonna see very, very, very commonly. These are our H2 blockers. The mechanism here is to suppress secretion of gastric acid. Common medications that you're going to see in the hospital is famotidine, also known as Pepcid. OTCs, you're going to see ranitidine, which is Zantac. And actually I have worked at some hospitals where for some reason or another they'll use ranitidine over famotidine, and I'm not sure what that rationale is. I assume it's typically cost. Preparations for these medications are IV and PO. When you're dealing with patients who cannot take PO, you're typically going to use the IV, but you want them to transition to PO sooner than later. This can be used in peptic ulcer disease. It can be used in GERD. A lot of times we use it in the hospital as a form of prophylaxis. If your patient is at high risk for developing one of these issues, or let's say they're on a ventilator and you're trying to prevent ventilator-acquired pneumonia, this is one of the methods that they typically use, but the evidence surrounding the use for VAP, or ventilator-associated pneumonia, is less favorable these days. Dosing tends to be 20 milligrams or 40 milligrams BID or daily, depending on the indication. Ranitidine is 150 milligrams BID or 300 milligrams daily. Now, just turning back to the mechanism a little bit. So if we're looking at using it as a therapeutic, this promotes healing by suppressing the gastric acid through blocking H2 receptors in the stomach, but does not block H1 receptors, so it does not reduce the symptoms of allergies. Okay, so keep that in mind. Nursing considerations for dosing. It should be decreased in renal impairment. IV push, it says IV push slowly over 5 minutes. For famotidine, you're typically in an IV concentration, you're going to dilute it. And then refer to your facility policies for your push, but you want to push it slower than your average drug because it can cause some cardiac dysrhythmias, especially if it's given quickly and undiluted, speaking specifically to famotidine. So let's jump down to anticholinergic agents. Now, some of the terminology used here jumps around a little bit, so we'll try and be as straightforward as we can, and we're going to speak specifically to first antispasmodics. So antispasmodics in the gut work by blocking the action of acetylcholine, and that's produced by nerve cells. And works on the muscarinic receptors in various smooth muscle tissues, and specifically we're talking about the gut. So by relaxing our gut muscles, we can relieve pain in conditions caused by the spasms in the gut. One medication is propanthyline. Oh, get out of here. Is propanthyline. And you'll recall a little bit from when we went over respiratory, when we talked about some cholinergics versus anticholinergics. So you're going to want to remember that anticholinergic drugs can cause dry mouth, i.e. some xerostomia, which is a word you will see again. So propanthyline is used to treat or prevent spasms in the muscles of the GI tract in IBS. In addition, it inhibits GI propulsive motility and decreases gastric acid secretion and controls excessive pharyngeal, tracheal, and bronchial secretions. So one thing I want to bring your attention to is the inhibition of gastrointestinal propulsive motility. So when we get down and start talking about Reglan, we'll talk specifically about the motility factor of certain drugs, which is something you should keep in mind, i.e. How things are being moved down the GI tracts. So doses for propanthyline is 15 milligrams. Side effect profile includes tachycardia, constipation, urinary retention, photophobia, and dry mouth. So typical anticholinergic side effects. Nursing considerations, using with caution in patients with a history of glaucoma, hypertension, liver, kidney, and lung disease, or myasthenia gravis, and you want to take 30 minutes prior to meals. Proton pump inhibitors, this is another very common class of medications that you're going to see. This is our typical partner to our H2 blockers. Medications in this class tend to be omeprazole or Prilosec and pantoprazole or Protonix. Pantoprazole is the most common formulary that I see, but you may have patients who are getting omeprazole as well. Mechanism of action involves suppression of gastric acid secretion through the proton pump, right? Preparations for Protonix can be, is typically IV, but it also depends on where you're at. Dose for omeprazole may be 20 milligrams daily, but can be altered depending on the indication for use. Again, very similar to your H2s used in GERD, PUD, and as a form of GI prophylaxis for patients at risk. Side effects include headache, diarrhea, nausea, vomiting. You can develop pneumonia from decreased GI flora, and fractures related to decreased calcium absorption, which typically happens in long-term chronic use. Hypomagnesemia, increased risk of C. diff. Nursing considerations you want to take before meals, Protonix either with or without meals. That's a good point because we tend to, in the ICU at least, we tend to give this to patients regardless of whether they're eating or not. So GI prokinetics, these are medications that increase gastric motility. Now this is important to note because in patients who are having a decreased GI mobility, whether it's from drugs or immobility, we may need to help this along by introducing something to stimulate the GI tract. And this might be seen in patients who have, let's say they're having nausea and or vomiting related to this. Zofran may not be your best bet. Your best bet may be to treat the underlying cause. But we're going to put a very bold asterisk on this medication. This medication can cause tardive dyskinesia type effects, which can essentially be irreversible. So when you have these patients, and I've seen this happen before where we've ordered this medication and I don't know how they find out, whether it be someone Googles it for them immediately. You want to be as proactive in educating your patients about the medications that they're taking, even if the risk is relatively low, because it's way better if you're upfront with this information as opposed to letting somebody Google the medication that they're on and then immediately finding out about tardive dyskinesia. that can be very problematic. Reglan is not really a drug that we'd like to use with neuro patients, but every now and then we do use it. It is a short-term thing. We're not going to use this long-term because of the risk, and it is contraindicated in patients with bowel obstructions. And common dosing is 10 to 15 milligrams. It may be before meals, but it also may just be on a regular schedule depending on what's going on with the patient. Anti-diarrheal medications. So we have loperamide and diphenoxylate, that's Imodium and Lomotil. This acts on the bowel to provide symptom relief of diarrhea. And one thing that I mentioned earlier is that this actually is potentially a drug of abuse. Lomotil itself is a controlled substance because it's an opioid. High doses, really high doses, can cause euphoria. So it's often combined with atropine to discourage abuse, and does have an anticholinergic side effect profile. So keep that in the back of your mind. Dosing for Imodium tends to be 4 milligrams initially, then comes in at, and then is generally around that dose range for subsequent doses. For Lomotil, it's 5 milligrams and it's at a set frequency of 5 times a day typically. Antacids and GI protectants. So this is actually a pretty heavy area, but we're not gonna wail on it too hard here. Aluminum hydroxide, calcium carbonate, Tums, magnesium hydroxide, Miltimag, and sodium bicarbonates and sucralfate. I have 10 years now and I still can't pronounce that word, sucralfate or carafate. So carafate creates a sticky gel that coats the crater of an ulcer. So this is something that you take, it's a bit like a thick elixir. And there's a treatment for PUD. It has no known adverse effects, but it can constipate you a little. Now, with any of these drugs, with any of the drugs, especially ones that reduce stomach acid, you want to keep in your mind the timing of giving this drug relative to the administration of other drugs, because it can slow down or hinder those. Now, these medications, specifically antacids and GI protectants, they react with gastric acid to produce neutral or low acidity salts, and thereby decrease destruction of the gut wall. Hence, if you have a crater from PUD, an ulcerative crater from peptic ulcer disease, it can be used to protect the gut from degrading any further and also kind of allow that to heal a little bit. You tend to have these medications dosed around the clock and tend to be very, it's 1 to several hours prior to a meal and at night. And again, with most all these medications, you do have this slightly increased risk for C. diff, but it is not a common complication that I've witnessed with these drugs. Jumping over to our magnesium hydroxide, this is a rapid-acting drug, but it also has another use as a laxative because it causes you to retain water within the intestinal lumen. So diarrhea can be a known side effect of this. Often the magnesium hydroxide and aluminum hydroxide are combined to reduce diarrhea if that's a problem, but also if your patient is receiving warfarin or digoxin, it can reduce those effects. We got a question. If you give a bunch of acid reducing meds, can you get metabolic alkalosis? Is that something we need to watch for? So you can have acid-base alterations, but I'm not going to dive into it now because we're running out of time. But let me make a note of it real quick. And the Q&A portion of the next forms that I send out next day or two. Where was I? These two drugs can reduce the effects of warfarin and digoxin, so keep that in mind for patients who are on them. Calcium carbonate is a common drug that you'll see. It's rapid acting, but it may produce acid rebound in patients, and this is something I've experienced personally in using this drug. That you have it, you feel good for a second, then boom, it comes back with a vengeance. This can produce constipation and gas, so you'll see burping and upper and lower flatulence. I've also seen calcium carbonate used as a form of calcium repletion, so keep that in mind as well. Sodium bicarbonate is unfit for treating ulcers, has a rapid onset but short duration, and causes gas and increases sodium. Sodium bicarbonate is fallen out of favor for the most part. Every now and then it might be used to treat acidosis, but there actually in certain formulations of sodium bicarbonate, there are black box warnings in terms of its potentially negative effect. There's also simethicone, which is it prevents gas formation, which can may be a problem for patients in certain circumstances. Laxatives. So there are several different types of laxatives. There's bulk forming surfactants, stimulants, and osmotics. So bulk forming, they swell in water and they form a gel which softens stool and increases its bulk. Increasing bulk stretches the gut wall, which stimulates peristalsis. The important takeaway is that bulk forming laxatives are not acute treatments. They take time to work. They can take 1 to 3 days to reach a therapeutic effect, but also remember that every patient is unique. So there can be patients who take, say they're prescribed something like Miralax, and they take it, and I'm like, oh, hey, because they're like, oh my God, I don't want to have diarrhea, and I'll say, hey, it's okay, I'll give them some education about it, and then lo and behold, that afternoon, they have horrible diarrhea. So every person is different, and even though for most people it will be fine, keep it in the back of your mind. Surfactants. These lower surface tension of stool, which allows water to penetrate into the stool. These take several days to produce the soft stool after starting treatment. The primary drug in this class is docusate sodium, also known as Colaze. This drug has heavily fallen out of favor. We used to give it to everybody, but the evidence for efficacy is not good. And we are seeing this fall out of use. There are still some places that use it, and they use it in higher doses, but don't be surprised if this drug completely disappears to some degree. Stimulant laxatives, these are more common ones. These stimulate intestinal motility and soften stool by increasing the secretion of water and ions into the intestine and decrease water absorptions. Now, it says 6 to 12 hours for results, which I would say is definitely true. There are some patients who can have an immediate effect. As I said, don't be surprised if certain patients have an immediate effect, but Seneca is the most common one used here. The other medication in this class is Dulcolax. Now, Seneca comes as a PO formulary. Dulcolax comes as a PO or a suppository. I tend to see us use Senna as a PO form and Dulcolax as a suppository in patients that haven't had bowel movement in about 48 hours. Remember that a suppository can produce results quickly. It can produce results in as short as 15 minutes to 60 minutes. And it's good for patients that can't strain, but when you're giving a suppository, remember safety things involved in giving that medication. One, make sure the patient's well informed and they're consenting. Don't just surprise them with a pill in their bottom. They don't like that. Two, make sure that you educate your patient and that once you introduce something into the rectum, it can feel like they have to go to the bathroom. In certain circumstances, you need to encourage them to hold it because these patients may just be stimulated through the introduction of these things into the rectum, and thereby they're like, oh, I have to go now, and then they just poop out the suppository, which happens often. Also true for enemas. Make sure the patients are, if you have a patient who's going to be difficult to get to the restroom, make sure that you in some way are preparing for the likely event that they have to go and they have to go now. If you have a patient who is at risk for falls, make sure that you are putting their bed alarm on or making sure that you can see them from wherever you are so that if this urge to use the bathroom hits them, that they don't just try and jump out of bed, fall, and then subsequently have diarrhea all over the floor.
Hey Ron, real quick on suppositories, something I found a lot of nurses don't know. Suppositories work when they dissolve. They dissolve because of body heat. If you put it in the middle of their stool, it's not going to dissolve. You want to put it on the side of the rectum so it's up against the tissue so that it becomes effective.
And that's something that you'll find if you keep, because a lot of times you'll find these suppositories sometimes in the fridge, depending on the formulation. And if you leave it in your pocket too long when you're transiting to the patient, that it can start to break up and be very difficult to get in. But that's a really good point, because I'll tend to, if it doesn't feel as pliable as it should, I'll keep it in my hand for a minute and let it warm up a little bit. Also, putting cold suppositories into people is not a nice thing.
That's very kind. That's very kind of you.
Yeah. Jump back. So going over to osmotic laxatives, these draw water into the intestines, which causes the stool to swell and soften. Swelling stretches the intestinal wall and stimulates peristalsis, very similar to the other one. These can be quicker if used for bowel prep. One thing that you will inevitably come across in your career at some point is a patient who has to undergo a bowel prep, whether it be through using Go Lightly or medicated doses of Miralax, which sometimes go hand in hand. But these patients have a long 12 to 24 hours ahead of them. So side effect profiles for bulking laxatives, those tend to be obstructive in nature. I feel like I tend to see, you tend to, in the implementation of bowel protocols, you tend to see multimodal therapy, meaning that you're going to see a patient who's on Miralax, they're going to be on Senna, and then they may be on a second or a third or fourth agent, depending on how intense their need is to get their bowels moving. I'll tell you that it is very easy to fall into the trap of not being very concerned about the average person. It's like, when they say, oh, they haven't pooped in like 3 or 4 days, and they go, well, they have a heart problem, and I'm more worried about that. What you cannot use that, you should not use that as an excuse to not be concerned about their bowels. Patients with brain issues, if they've gone 3 to 5 days without having a bowel movement, I don't want them straining to get a 3 to 5 day old bowel movement out. Patient with a heart issue, I don't want them straining to get a bowel movement out. I want to be more proactive about getting their bowels moving as soon as possible. So it's something that you want to try to not take for granted. Bowels are important. Osmotic diuretics can dehydrate you. Miralax can cause cramping and bloating. This is something that's very important. If your patient's having cramping and bloating because they have an ileus or a small bowel obstruction, pouring a little bit of Miralax on that can be like pouring gasoline onto a fire. So it's something to keep in mind. We may use Miralax if your patient has an ileus or a small bowel obstruction to help them move, but if their bloating becomes too severe, you need to seek another form. Lactulose is one that that in my practice I've not seen used a lot for this case, but it's not to say that it does not occur. Lactulose is a little bit like killing a fly with a shotgun, but it works. Also in patients who have liver disease and you need to get their ammonia levels down, you can kind of kill two birds with one stone in that method. Nursing considerations, and this is something that I do want to draw your attention to and that you should know, is that laxative abuse can diminish reflexes, which leads to reliance on laxatives. So if you have a patient who maybe they have issues with anorexia or what have you, but people may fall into a cycle of laxative abuse, and you can become chronically dependent on laxatives for the rest of your life. So it's something that you need to be on the lookout for. So we're going to talk a little bit about some of the meds used in inflammatory bowel disease and ulcerative colitis, but I'm not going to dig too deep into it at this stage. So there's a whole fleet of medications that are intensely difficult to pronounce, that typically involve the modulation of autoimmune or inflammatory responses within the body, i.e. they're immunosuppressants or pseudo-immunosuppressant type medications. So infliximab is a medication that's used which inhibits tumor necrosis factor alpha, TNF-A. This can be used in ulcerative colitis and in Crohn's. Now remember, with any form of immunosuppression, and typically any drug that ends in like MAB tends to be an immunosuppressive type drug. You can have issues with opportunistic infections. So look for signs of infections, fever, chills, chest pain, rash, hypotension. And it is important to adhere to these schedules, and I can attest to this. These patients need their drugs and they need them in a timely manner. These drugs are not curative, they're meant to control their symptoms. So keep that in mind. Patients can be on what is the word I'm looking for? They can use several different types of medications to help control symptoms, and at times certain medications may become less effective and may require that they switch to different types of therapies. Sulfasalazine suppresses inflammation as well in ulcerative colitis and Crohn's. Side effects are very similar, plus add in potentially orange skin or urine. I really want to draw your attention to orange urine because it is something that even outside of bowel medications that change the color of your urine, you need to be aware of, because there are times there are situations in which when you combine, let's say, an orange urine profile with someone who may be very dehydrated, maybe has very amber dark colored urine, you can produce urine that looks very similar to bloody urine. So you want to be aware of that before you sound the alarm. I very recently had an issue where I called the physician and I was like, hey, this patient's having some bloody urine, and they came over and looked and they're like, are you sure it's not orange? And I was like, and then we looked at the medications, and I actually don't recall which medication that they're on, so they're like, no, it's that. But it looked very, very similar to bloody urine, so it's important to note. Another thing to know about these medications is that they are very expensive. And I hate to say this, but there are certain patients whose medication regimens isn't dictated by what they need, but rather what insurance will pay for. And I've seen this happen several times, you know, in the course of my career where patients were on medication therapy that worked, but the insurance company either wouldn't pay for it and or they could not pay for the costs out of pocket. So we have 6 minutes. So antibiotics for PUD with H. pylori infection. So jumping back to peptic ulcer disease, these patients are typically infected with the Helicobacter, and thus we need to treat that and also treat any issues that are coming with it. Now, as far as antibiotic therapy goes, business subsalicylate, good word, business subsalicylate.
Say that one more time, please.
Yeah, 5 times that. Clarithromycin, metronidazole. Those are some options for treating there. It's typically recommended once this is diagnosed that you're going to use at least 2 antibiotics. Often, I would say the most common that I see is metronidazole. That tends to work very, very efficiently. So just jumping down those 3 meds, your bismuth disrupts your cell wall, causing lysis and death. And remember, this can turn your tongue and stool black. I personally never seen a patient give this drug, but just like the urine, if there is a med that can turn your patient's tongue black, you should know about it, because in other circumstances, that is a very bad sign. Jumping down to clarithromycin, this inhibits protein synthesis. Side effect profile, nausea, vomiting, diarrhea, changes in taste, and it has interactions with warfarin. We're not going to dig into that. Metronidazole, this is the most common drug that I've seen. Side effect profile includes nausea and headache. Avoid alcohol, and this also increases the effects of warfarin. So treatment, in addition to antibiotic therapy, should include PPIs or an H2 for 10 to 14 days, but may extend longer depending on the physician. And adherence may be difficult due to the number of pills which must be taken, as well as the side effect profile. While we recognize that nausea, diarrhea tend to be common with antibiotics, for some people it can be very profound and can cause a lot of discomfort. And that is it. So I'm going to, so I sent out some stuff yesterday. I'm going to take the 2 PowerPoints we've covered, as well as the remainder of the last PowerPoint, and push it into a Word document. You should go over that and pay attention to anything that's marked, because that is things that you might see again in the very near future. If you have any questions, email me. If you email me a question, please CC everyone. It's about content, that way I can respond. So just to avoid having to say the same thing over again. And I will also include those in the next form that I send out, so that way there's kind of a Q&A section for any questions people might have. All right?
When are you thinking about the exam, Ron?
Did we say Monday?
We talked about Monday?
Yeah, I believe that's what we said.
Okay. Oh, we have a question from Catherine.
Are we moving on to the next content, next module?
One more?
Are we moving on to the next module tomorrow?
Probably. Any plans for tomorrow?
I don't have anything on the docket for tomorrow.
What I'll probably do is we'll go over like an unfolding case scenario specific to gastrointestinal, and then we'll move on to the next subject.
Sounds good.
So will our quiz be on the next module?
Hmm?
Tomorrow morning, will our quiz be on the next module?
Tomorrow morning we'll have part of the next module, and I hadn't anticipated it that fast, but we'll get it done.
The quiz tomorrow will have the immune stuff on it, right?
We just had quiz 6, right?
So will there be a
I
quiz
think
tomorrow?
it's quiz 6.
There may not be a quiz tomorrow, and we only have 4 more after this, maybe we'll just.
Well, thanks.
No quiz tomorrow.